Record. All right. Is everybody heard that little message?
Yep.
All right. Thank you for the reminder, Haley. Um, okay, well, so now without further ado, I'll go ahead and get started. So before we get into the explanation of what exactly Detor is, we wanted to briefly just level set on the problem that we're trying to solve. And the short version is that, and I think everyone on the line would agree, public health laboratories play a really critical role in our country's infrastructure. Um, they keep us safe from disease, they detect and prevent outbreaks. They're one of our first forays into the world via newborn screening panel testing, which is, truly foundational to public health. Um, so that said, they've also struggled to set up efficient and consistent methods for communicating electronically. And in a digital world, are still very much relying on a lot of manual and paper-based solutions that are increasingly obsolete in the private sector. So these solutions are, time intensive, and I'd say time is probably the resource everyone has the least amount of. They're also prone to transcription errors, things like missing fields. They may require a lot of follow-up. And all of that can really delay the critical sharing of information for patients that may need intervention or treatment. So we know that public health labs need to enhance their ability to exchange electronic test orders and results. Um, but the methods that are also currently available are inherently problematic. So what you have here with this little diagram is kind of representing the current state. A public health lab may set up a direct connection with a provider, but they have to do that with every single partner with whom they want to exchange data. So these multiple point-to-point connections um, not only have to be built, but they have to be maintained over time. The work on one can't necessarily be leveraged for the next one. So there are really no economies of scale, no reusability. You may have to meet different standards or different parameters for each and every one of your partners. And then across the landscape, this has to happen hundreds of times. Lab A, B, and C might be doing exactly the same thing and exactly the same work, but they're all doing it independently. And they all have to kind of reinvent the wheel each time. So resulting in a real redundancy of effort. So Detor is again, it's electronic test order and result intermediary solution on the AIMS platform. And we launched it truly to be a shared solution for all of public health. Instead of setting up multiple point-to-point connections like you saw on the last screen, a lab could set up a single interface to Detor, which essentially would act as a single pipe. And through that pipe, any partner could connect. Um, then because we are developing all of the configurations and mappings and messaging centrally, we can deploy and share it across the landscape. So the work that we are doing on an implementation is absolutely used to inform future implementations in a way that is not really possible with the direct connections. And we can reuse the development and design for every single lab and every single provider that we onboard. So it's not happening hundreds of times for everyone independently. It's happening once centrally and again, built upon over time. And the other benefit is that every organization is able to use their native and preferred messaging format. So there's no need to negotiate and build to anyone else's standards. So really, as soon as an order is generated in say, a hospital's EHR, it is sent directly to Detor, where that message is translated to the format required by the receiving public health laboratory. They get that order, in their language, so to speak. And then when that result is available in the LIMS, it kind of does the reverse on its way back. So they send it back to Detor in their format. It gets translated and routed back to the EHR. And I should mention those results get sent back as discrete results into the EHR where they're available in the patient chart. So that eliminates, some of those manual processes on the result receiving side with like manual, PDF uploader or something like that. And then finally, because everything that is built centrally is reusable and shareable, the solution also becomes more efficient and cost effective the more widely it's used. It's kind of like a snowball effect. There are only so many systems and messaging formats that exist. So at some point, building them centrally, we will have configured all the possibilities and they will be more quickly deployable with every implementation. So now we wanted to kind of walk through, really tell the story of the last year and a half of Detor. We wanted to share, some of the timeline and what we've learned and seen along the way, because I think we saw a lot and learned a lot that we hadn't originally anticipated. So here we go. Okay, so in August of 2024, we went into production with the state of Florida and their partner Orlando Health for newborn screening. And just to mention the number in that box on the HCO column on the left, that just indicates the number of facilities in the healthcare system using Detor. A couple of months later, we went live in the state of Iowa and with their ordering facility, Fairbanks Memorial. So this was kind of interesting because it opened up some additional ideas and possibilities about healthcare organizations, which of course don't necessarily, they don't follow state lines. So Iowa conducts the newborn screening test for a number of states, including Alaska. So that said, as soon as Fairbanks Memorial went into production with Iowa, they realized that they could theoretically in the future also use their Detor connection to send their other public health testing orders to the state of Alaska. So now, a couple months later, with only our third implementation, we're already starting to see some reusability kick in. We're seeing some overlap in systems. And during an implementation, we work very closely with the on-site staff, of course, at each organization. So say at a hospital, their Epic Beaker team, for instance. But then centrally, we're also working very closely with EHR vendors like Epic and Oracle. And from a centralized standpoint, to start building with them more standardized template solutions so that any Epic client, say, could theoretically add on the Detor connection. So as we connect hospitals with the same EHR to laboratories with overlapping LIMS, there's inherently some reusability baked in, and we're able to plug and play to a degree. Okay, now things are getting more interesting. So once Iowa went live, they of course wanted to use it for other sites to capitalize on their connection. So we began working with a hospital in North Dakota. Which the state of North Dakota also submits their newborn screening orders to Iowa for testing. For that one, however, we actually ended up connecting to the state's HIE, which was our first time doing that. But that model sort of opened a lot of doors for even more efficiency potential. We can connect to an HIE and through that connection be connected to kind of their connectees, so to speak, almost like an intermediary to intermediary approach. But what I especially want to call out here is that since Iowa was already connected to Detor, their role in their state's second implementation was significantly easier. It was about an 80% reduction in effort on their side once they were already in production. And we would certainly expect to see that for any subsequent implementations as well. So really during that one, we worked closely with the HIE and the hospital there, and the public health lab didn't really have to come back into the picture until testing and validation. So here, I just want to mention that obviously this was very much a solution developed for public health and for public health laboratories, but we're seeing a tremendous response from healthcare organizations, HCOs as well, and even enhanced interoperability for them. So as I mentioned before, there are some exciting opportunities due to the fact that healthcare organizations don't follow state lines. So our next implementation was with Alabama and their partner Baptist. However, that implementation was really driven by the fact that Orlando Health was in the process of acquiring some hospitals in Alabama and wanted to use the solution there as well. Um, our most recent newborn screening implementation was with the state of Louisiana and their partner Ochsner. And again, I just want to point out here that the overlap and redundancy that we're starting to see in the systems at play. So the ability to leverage builds for systems and use cases is only growing as we onboard more users. And then finally, our last go live marked our first clinical implementation. So up until New Hampshire, we'd been solely focused on newborn screening. But with this implementation, we went live and into production for tuberculosis and STI testing. And we're slated to go live later this month with 2 more public health labs and 37 healthcare organizations for a variety of clinical use cases. And we have several active implementations underway right now for newborn screening and for clinical. So we're really excited. In this first year and a half, we've demoed success with 4 EHRs, 4 LIMS, and more to come in the months ahead. So now that we have results to share, we wanted to do that with all of you. But really, we're seeing some really promising and exciting results with Detor adoption in terms of efficiencies gained. And I guess by efficiencies gained, I don't just mean like smoother processes. I mean faster turnaround times. It's doctors having the information they need 4.5 days faster than they did before. And if you think about something like tuberculosis, where somebody might be held in isolation, doctors might be waiting to figure out how to treat that person. A faster turnaround time can obviously have a major impact on outcomes, not to mention costs. If a hospital can treat someone sooner, they can discharge someone sooner too. And the time savings have been really extreme. So by eliminating the need for manual data entry, and some of those processes like uploading results, labs are saving incredible amounts of time. There's no demographic information to key in. Hospitals too are seeing an average of 10 minutes saved per test. There are a few stats that we wanted to call out that we thought were pretty impressive. For Fairbanks Memorials, they're getting their results in the EHR 6 days faster than they were before. Orlando Health, mostly because they have such a high volume of tests, by eliminating some of those manual order and result processes, they're actually saving more than 125 full-time days a year on that loss of or on that elimination of manual processes. And that's obviously quite a lot of time, for providers to be focused back on what they want to be doing, providing patient care, not on data entry. And then by transmitting the orders and the results in I guess what you call their purest states. So from the EHR, it's direct, like it's that information, what's in the EHR is what the laboratory receives, and vice versa for the results on the way back. We're also seeing some really major improvements in data quality. And this is something that's a little bit harder to capture and to measure. But what we've heard from labs is that this has eliminated their, I guess, what used to be fairly common follow-up. The need to call a hospital and say, I can't read this handwriting. Is this a U? Is this a V? There's a field missing here. I don't know what to enter, and I need to put something here. That's all been removed from the process. And so we're also hearing from providers that by having the discrete results directly sent to the patient chart, as opposed to, say a PDF upload or a printout or fax that someone might have to enter in, it's making for much more streamlined care. So say a newborn has a condition that requires follow-up and treatment. There's not a constant back and forth of please send so-and-so my patient's results or upload to this portal so a doctor over here can see, um, or a family that's trying to hunt things down while also dealing with the incredible stress of trying to figure out care for their new baby. Those results are tied to the patient chart. We also, so we're very excited about some of these, the impacts that we're seeing here, but we did want to introduce some of the laboratories that are using Detor, to sort of hear some of their stories and the impacts they're seeing in their states. So we're joined by Allison Sadie and Kelly Dugas from Louisiana and Nalima Vundela from Alabama, to talk a little bit more again about the impact they're seeing in their respective states. So I think Allison, I think I have Louisiana up first if you want to speak a little bit to that.
Yeah, absolutely, Rachel. Thank you so much for having us. And thank you so much for working with us to implement this. We implemented in November of 2025, and we have definitely seen all the positive attributes I think that we thought we were going to see going in. Definitely better data quality, better daily work practice by our data entry people, less frustration on the daily of what's this letter, what does this say. We've decreased the corrected reports that we've had to issue because of demographic entry problems. We are saving, as you can see, 59 hours a month, time wise from data entry. We get about anywhere from 3,000 to 4,000 a month. And we currently, with our implementation in November, we had about 20 to 25% of our samples are coming through Detor as well. Ochsner, our hospital organization that implemented, is seeing some incredible improvements for sure from efficiency, but just the satisfactory job wise, the nurses not having to write everything. They can put a label on the sample now, and the information needed on that label, our scientists can read because it's printed and it's clear. So there's a lot of the data quality is a lot better, but there's a lot of I think decrease in frustration and improvement in just day-to-day work product and the morale of people having to do these work tasks. And we're getting, from that order to results getting back to Ochsner. They're getting it in their charts 10 days sooner. We have a portal where they could always get those electronic reports, but this is, obviously syncing up directly. So there's a lot of improvements to be made, and just our experience. Kelly she's on the call as well, and she works with this staff every day. But Kelly's a manager in support services, and I'm assistant director, and we are the ones who worked to help get this implemented. Not a whole lot of IT expertise. We definitely leaned on APHL and Natus as our vendor to do a lot of that. So I know if we could do it, anybody can do it for sure. Kelly, do you have anything to add?
No, just to reiterate, just the changes in workflow flow practices have just made a huge difference in the data entry department. The calls they are making to figure out some illegible writing and those kind of things, that's just completely we've cut that down so much now that it's been such a great improvement. Highly recommend it. The work is worth it. And to me, it was not a huge heavy lift for me and Allison. APHL and Natus, they did most of that heavy lifting for us. So don't be afraid to jump in. You can do it.
The other one thing I wanted to add is, so we implemented this in November, and we have our to-do list of who to reach out to next for expansion, and another hospital organization actually reached out to us first, saying, we hear this is happening at Ochsner, and we have 5 hospital facilities. We would like to start initiating this. So it kind of speaks for itself in the community as well.
Well, thank you both for sharing. And that's a really interesting point. Obviously we're in the public health side, but We have had a few instances of hospitals saying, we hear they're doing this over here. Like, I'm like, oh, hospitals talk too. Okay, that's great. But I would say Louisiana was an incredible team to work with, and we're really excited to expand. So thank you both. And now Nalima, are you on? Are you on the line?
I'm here.
Hey, Nalima, thank you so much for
Thank
joining. Do
thank
you mind
you.
sharing a little bit about, Alabama's experience?
Rachel, do you want me to start with the report stream?
You can go back as far as you want, as high level as you want. We're any story you want to share. We're all for it.
Okay. Hi. Hello. Good afternoon. This is Nilima. I work with the Alabama Department of Public Health. Um, so we started this project with the report stream 2024. So we worked for almost a year with them on the vocabulary connection. Um, uh, After we decided, okay, Baptist Health is going to be our pilot hospital to work with report stream. So we were trying to get the connection. And then we have to pivot to APHL Detor. When the news came out in 2025 that Orlando Health purchased 6 hospitals in Alabama. So we were like, okay, Baptist Health, if I go with Baptist Health report stream, and then I have to work for a year and a half again with another connection for a detour because 6 hospitals were purchased. Orlando Health already has a connection with the AIMS platform, whereas Baptist Health, I'm working with the report stream for about a year and a half. So it was a tough decision because we were almost got the requirement and data workflows by the hospital and us and report stream. Then we made a decision, okay, let's do it with APHL AIMS platform because Orlando Health, Florida is already live and it should be easy for us. But it's just scary. I mean, literally it was scary because year and a half we worked with one full team. Then all of a sudden within a month, I have to work with a totally different team, start from the beginning. So we kind of put it on the table. Do we need to start from the beginning again, like vocabulary and connection and Rhapsody, because I have Rhapsody, and then natives as well. So it's called as giant wheel rotating. So then I talked to Rachel and Keith Higginbotham. He was my boss and he works with APHL now. So and Manjula as well, who works with CDC on this project, they all of us helped us saying that, okay, no, Alabama will be in good shape. And they actually, Detor AIMS promised that it should not take a long year and a half of work needs to be redone, that have to again turn the wheel to put AIMS in now with as my intermediary with the Baptist Health. Because I know I'm handling it from ADPH side, but I have to think about hospital as well because hospital was also involved. Their EMR people were involved with report stream. So now I don't want to be in a bad business relationship with Baptist because, hey, after a year and a half, why as a state you're changing your stake with AIMS, APHL AIMS platform. So we need to come up with a real justification. So our justification was, this is the proposal. CDC proposed this in the past, but now I have to have as a state 2 different connections just purely because Orlando Health purchased it. So, and after we talked with the hospital stakeholders and ADPH stakeholders and APHL and CDC, we decided with using AIMS. And I think 3 to 4 months we were doing validation testing. I'm very happy when Dory and Alok and Keith came by and started helping us, holding our hands, especially like, hey, Nilima, we can do this. So within 4 months, we were live, worked with Oracle, AMR, which is Baptist Health. And my team, at the time, again, I was not just by himself. We were like 3 people working. And I had to, one of my contractor left. So it was just me and one of my colleague as well. So 2 of us from the ADPH side worked with the APHL and went live with Baptist Health. So it was a really good experience. The trouble that we went through by changing the intermediary and not hurting the business partnership with the Baptist Health, which is very important. And finally, the product is good. We right now, our newborn screening demographics is the first one who actually benefited with this. All the key is the form number, and it populates everything for them. Even, I mean, in the beginning when I was explaining this with our demographic staffs, they were like, Nilima, what is the trust? Trust is a second thing that my staff has to, who actually does this job every day. They were not trusting it because they were not used to it, because they're always used to the paper. Look at the paper here and double verify on the paper here. So to bring that trust, we sat with them and worked along with the APHL AIMS team. And Netra, who is actually asked her to come in as well. We worked with them and they started trusting the system. Now we are successful with that. It's very fast. The results go electronically. It's been almost a year. By July 27th of 2026, we've been live with it. And we are in the process of bringing on board 2 more hospitals who is using Orlando Health. I really like it, love it. So thank you, APHL team, for doing this. And we are also working with the AIMS team to do our first clinical LIMS as well. So one of the biggest, and again, who in the past I talked about this with a couple of people, they will laugh at me again. So with AIMS as an intermediary, and again, I'm an IT employee, AIMS does the magic. You don't do anything. But I like to put my hands on it, but AIMS won't let you. So that is the thing I didn't like it, but that's okay. Okay. As I'm bringing on more point-to-point connections, so for our clinical LIMS, it's point-to-point connections. Like I have right now 4 different EMRs connected to our clinical LIMS who sends electronically all the data. It is getting harder. So I'm not sure if Keith is here, okay, on the call. So in the past, I used to, when Keith mentioned about this Nilima we can use, and I used to tell him, look, I don't want someone to do my job. I want to do my job. But now in the management level, I'm thinking okay, this is getting harder to manage point-to-point connections with these different EMRs. And then they won't send, even though you give your specifications, hey, state is looking for these specifications, still they won't do it. Each EMR is different and they have their own fields required, and it is getting harder on us to maintain those point-to-point connections. So we are working with our clinical LIMS with AIMS intermediary. So we have just initiated our call with a couple of the new providers, lab providers who are interested to have a connection with us. So we thought, okay, no, we need to stop doing this. Let's start AIMS intermediary and see how this one goes. So we started talking, introducing clinical LIMS with AIMS intermediary. So when I said this decision, my employees who are developers, they came back and said, Nilima, we don't like it, Nilima. We want to do the mappings and we want to do the coding. I said, look, management side, if you think at that level, this is the easier path. AIMS just does everything for you.
And Nalim, I think you make a really interesting point, a couple of really interesting points. One is that, like you said, this isn't going to replace all those point-to-point connections right away, but every laboratory kind of has the maximum number that they can hit and sustain because of all those different requirements they have to meet and because of just how complex it is to build and maintain all those different specs. So yeah, thank you for sharing a bit of your story. And I also want to, it is really interesting to talk to all the labs and all the hospitals because it's a big deal to replace your processes and your workflow and to change things drastically because this does kind of, some of the impacts that we've seen in hospitals and in labs have been pretty drastic. So it is a big deal, and it, I think it's reasonable for labs to really want to understand, what they're getting into because it does change things. But thank you, Nalima.
So I see one of the questions someone asked about data entry staff. So between Etor and before Etor and after Etor, and again, I have two different systems, one for newborn screening, one for clinical. We did know 80% of our Etor, of the specimens that we received, we still have the same number, whether it is on the paper or it is on the electronically coming. The reason is you're not doing any manual entry mistakes. That is what you're looking for, and faster transmission of the data. So to that question, no, we have the same staff. And especially during COVID time, this helped us cross-training. I'm not sure about you have learned this. So during COVID, some of the staff for newborn screening had to take off because they got COVID. We had delay because no one knows what to do, what points needs to check at the time when they key the demographics for newborn screening. I had the same situation, clinical as well, but it's easy to train. You're scanning a barcode and all you're doing is comparing it, what you see on the screen with the paper, and done with it. So that's the benefit that we had with Etor versus paper.
Yeah, thank you. And I thank you for answering that because I couldn't see the chat. I just pulled it over, but thank you for being on that. I just have a couple more slides and then we'll open it up for kind of larger discussion and certainly questions if there are any. I really briefly wanted to mention we do have a Detor Resource Center that is publicly available. And here you can read some of the specific stories from different sites and states that are in production. You can see some of our news coverage and review. What it might be of interest is actually reviewing our implementation handbook. And that really gives kind of an overview of what the process entails, who needs to be involved from each organization, what you can expect with a timeline and so on and so forth. I think you should be able to scan that little QR code, or you can visit that link above to gain access to that. And I did see in the chat, we will share these slides after, so you can always grab it when this comes out. And then my last slide is just to talk a little bit about Detor in the future. So we're really proud of the work that we've done these last couple years. We're really excited about the results that we're seeing, and believe that Detor is making a big impact in public health's ability to achieve Detor. But obviously, this is for the public health community. So we need your support, we need your buy-in, and most of all, we need your voice to make sure that this is and continues to be a solution that you want and need. So we're kind of at a critical jumping off point, really, a critical juncture where the goal in that first year was to prove technical viability, which we've more than done. But in order to fully expand nationwide, work is currently underway to ensure long-term sustainability and potential for growth. So we're working closely with members to define some of those costs around the eTour landscape to really demonstrate some of the potential for long-term cost savings and return on investment when laboratories do adopt a centralized solution like Detor. We're also very excited about some of the things we have on the horizon, including the adoption of Detor for more clinical testing. That would ensure, in the event of, say, a pandemic, which we hope doesn't happen, but likely at some point will. If a lab is already connected to Detor, they're really prepared to accommodate a high volume of orders and transmit a high volume of results with great speed and relative minimal level of effort. We're also starting to explore different kind of sender and receiver models. So thinking about some of those like public health lab to public health lab implementations for like routine testing and surge capacity. Really, with the Detor model, we need an order and we need a resulter. Who they are is kind of irrelevant, so long as the functionality exists within the systems to generate orders and consume results, and I guess do both. So we're looking at those types of implementations now. And in the future, we want to expand functionality. It's a goal to include ELR in this. So basically, if a test goes through Detor and the result is reportable, it would be ideal to kind of be able to fully automate that workflow and actually follow up with the reporting through Detor as well. Again, that's long-term functionality, but these are just on our future roadmap. So with that, we're also exploring national initiatives like, could this be a supported use case within TEFCA? We're also working with labs and providers to see if there's potential to encompass this within the Rural Health Transformation Grant, as this has really impactful implications for rural and critical access facilities. So these are some of the things we have coming up. But we really do want to take a moment and hear from you. I do want to open the floor for discussions and questions. But before we do that, we have a very quick poll, 3 questions, just about your organization's potential interest in using Detor. It's anonymous. It's anonymous in that it won't be on the screen. We will receive the results internally. It will just come back to us, and it would just be very helpful for us to help gauge interest in expansion and need across the public health landscape. So we do ask that you only respond if you're representing a public health lab or a healthcare organization. But Haley, if you don't mind launching that, I'll give a moment for the poll, and then we'll certainly have some time for questions and discussion. Okay, I'm going to keep it open for maybe 20 more seconds or so. Okay. I think I can leave it open for another minute. If you haven't answered and would like to, please feel free. But I think at this point, um, we can we can jump into some of the discussion. Um, Haley, I don't know if you were kind of looking at the chat and anything came up in the chat that's worth raising here, or if anything was able to be answered. Oh, now that I see it, I see there's
I think we've been answering
okay, thank you. I see.
throughout. Yeah.
Great job. Well, with that, I'll just open the floor and oh, I see somebody was on as me. I'm like, I didn't answer any questions, but okay. Um, if there are any questions or any comments, please feel free to come off of mute and introduce yourself, and we'll do our best to respond.
There is a question in the chat that asks, would ELR include CDC reporting to programs such as FLIP, LRN, ARLN, etc.?
Thank you for reading that. I think that's definitely up for discussion. It could. I think right now um, I think the sooner capability would probably be the PHL to PHL or state reporting. But ultimately, I think this would be ideal for exactly that. Any other questions or comments? Okay, well, going once, going twice. If there is nothing else, oh, I see one more question from you. Would or can Detor provide a way to get some AOE questions that may not get answers from EHRs? I believe so. I'm not sure if anyone is on from our technical team might be able to address that better than me. Hugh, I'm probably not the best one to answer that. Let me look and see if there's anyone here who may. Um,
Wouldn't it require a separate interface, Rachel? I don't me I'll leave it to you guys to answer.
Brendan, I'm always up for your answers are always pretty good. But look, I see you're on the call. Do you mind responding to Hugh? Is that something you can
Sure,
speak to a bit?
I can take a crack at that. I'm not 100% sure on what the question is trying to get to. But we do need to receive all of the information in a single message. So if there are multiple systems like EHR versus lab versus like a hospital registration system, there's something that has to aggregate the data that is going to be coming into AIMS within a single message, and then we can transform it as needed. But we don't take multiple different sources and try to merge those together into a single cohesive message, if that answers the question.
Hugh, is that what you were kind of getting at?
Yeah, pretty much.
Okay.
More or less the EHRs. They're going to need to configure whatever AOE questions that you need. It may be easier for them to configure, my thinking, but
Yeah, but the EHR, you get the birth weight from the EHR, but a lot of labs need that current weight. And then, of course, Tennessee, we get CCHD and hearing data as well. And a lot of that's not going to be in the EHR.
So I think right now, because we are working in some states that have that hearing data as part of the as part of the order. And I think right now it's kind of going through a separate mechanism. So it's not part of it's a little hard to say because the like what in the state of Florida, for instance, I think that Orlando Health had already had like an electronic way to send hearing data, and it kind of bypassed the public health laboratory. So they kept that, they just kept that approach because we didn't, that was already kind of set up. But I don't think right now the CCHD and hearing data is included via Detor, I believe.
So I just want to nuance that a little bit. Orlando Health in Florida, they have a system where they are aggregating their data, their hearing data, as well as data from their limbs and the EHR, and it aggregates that all together into a single file, a single message, which they deliver to us. If they do that, then, basically they're taking care of making sure the hearing data is coming in, even if it's not a part of their laboratory system. If we receive the data, we can transform it and deliver it as AOEs as needed. But if the CCH, if the hearing data is in a separate system, and the order is coming in from a different system, we would not be able to merge that. But, basically we are routing the orders coming through. So if it doesn't come in with the order, we can't grab it from a different system or try to merge that.
So you're not getting ADT messages, storing some information in a database, and then getting other information. And then when somebody clicks send everything to the PHL, you don't have that type of capability. Everything's going to
No,
come
we
at
we
you at
do
one
not have a
message.
repository. We don't handle ADT messages. It's really just the order messages, the ORMs, or OMLs, things like that.
Okay.
Thanks, Alok.
Sure.
Any other final questions or thoughts, comments? Okay. Well then, really just appreciate you joining today and learning a little bit more about Detor. We appreciate your time and thank you for jumping on this call. I will send out the slides tomorrow, so you can have access to this information and some of the links therein. And I'll make sure the recording is available too from when we actually started it. But again, thank you all for joining and hope you have a good rest of your day.
Thanks, everyone.
Thank you.